So welcome everybody on this Saturday, either morning or afternoon, wherever you are in the world. My name is Ruth Bush, and I am filling in as lead moderator for Dr. Sarah Oneida, as she is busy in practice today. So welcome to Vein and Lymphatic University's EmPowHER webinar series. We will first start with hearing some messages from the board of Vein and Lymphatic University. Oops, if you can, yeah. If you can take those slides off, that'd be great. We will first listen to Dr. Lowell Kabnick, who is chairman of the board of Vein and Lymphatic University, and Dr. Victor Kanata, who is the president of Vein and Lymphatic University. If you could play those videos, please. If we could play the welcome videos from Dr. Kabnick and Dr. Kanata.
We have just the presentation of Dr. Chernukha, no welcome videos.
Okay. All right, well, as I said, Dr. Kanata and Dr. Kabnick are the executive board of Vein and Lymphatic University. And this EmPowHER Venous Education Series is every month. And so we welcome you, and you can put my slides back up. So today we will be talking about lymphedema. Next slide. First, I'd like to thank our sponsors for their generous and gracious support of this EmPowHER webinar series, which brings experts and learners together on topics pertinent to venous and lymphatic medicine and surgery. Boston Scientific and Medtronic have been very generous in their support. Next slide. So this is our amazing group of panelists. We will first have a video presentation from Dr. and Professor Larissa Chernukha, who is from Kiev, Ukraine, the Department of Vascular Surgery. She is currently Vice President of the Association of Vascular Surgeons, Phlebologists, Angiologists of Ukraine. We will then hear a video presentation from Ms. Dancey, who is a consultant plastic and reconstructive surgeon in the United Kingdom. Third, we will hear from Dr. Erben, who's an Associate Professor of Vascular Surgery at the Mayo Clinic in Jacksonville, Florida. And lastly, we will hear from Dr. Olivia Ho, who's an assistant professor of plastic and reconstructive surgery at the Mayo Clinic in Jacksonville, Florida. We will take time for discussion in between some of the presentations. Next slide. The objectives of all of these presentations are here, and each of these experts will be presenting in areas of their expertise and their approach to these patients, who can be quite challenging, as well as conservative and surgical management. So we will get started with Dr. Chernukha and her presentation. Thank you, and thank you all for being here.
Good evening, dear colleagues. It is a great pleasure for me to take an active part in such a scientific webinar. I want to present a clinical case, a patient 35 years old with chronic lower extremity lymphedema and several episodes of erysipelas and cellulitis, admitted to the Department of Vascular Surgery. The patient has been suffering from giant lymphedema since 15 years. The patient did not have a history of lower extremity surgery or trauma. According to data of physical examination, significant increase in the volume of the lower extremity, subcutaneous edema, large areas of fibrosis, heart swelling, papillomatosis, constant lympharia with cellulitis. What is the preliminary diagnosis? Primary lymphedema or lymphatic malformation? We know that lymphedema is complications that develops when lymphatic vessels and nodes are damaged due to the trauma, tumor, inflammation, parasitic invasion, or congenital defect. defects. And lymphedema is a disease that occurs as a result of impairment of lymphatic drainage at various levels of lymphatic system. And anatomic or functional obstruction of the lymphatic system can result in the progression, accumulation of protein-rich fluid in the interstitial spaces. According to epidemiological data, lymphedema is estimated that up to 300 million people around the world suffer from lymphedema. Unfortunately, we had not such epidemiological data in Ukraine, but in the United States, for example, lymphedema affects an estimated 35 million patients, and lymphedema is the forgotten vascular disease. We know that we have primary lymphedema and secondary lymphedema. And the vast majority of lymphedema worldwide in secondary lymphedema, particularly after traumatic breast cancer surgery and gynecological surgery. According to International Society of Lymphology, we have different stages of lymphedema, and our patients had a severe stage, third stage of lymphedema. And according to guidelines recommendations, we must use lymphedema assessment, which include lymph volume measurement, circumferential measurements, and duplex ultrasound, recommended computer tomography, MRI, and lymphoscintigraphy in the cases in patients in whom the diagnosis is unclear. We must use such methods. Come back to our patients. A lower extremities ultrasound was not performed due to the technical problems. Ultrasound of retroperitoneal vessels showed no changes. And a problem with methods of such as computer tomography, MRI, lymphoscintigraphy, due to the presence of large areas of fibrosis and large lymph volume, we have some problems with performance of such methods. Which method of treatment can we use? We have guideline recommendation, and we know that goals of treatment for lymphedema are reduction in lymph volume and both prevention through better skin care and aggressive treatment of infections. And for example, the main approach in the treatment of lymphedema, usage of conservative care. In the first phase of treatment, the intensive phase complex decongestive therapy, which combines manual lymphatic drainage, multi-layer bandaging, skin care, and exercises is recommended according to modern guidelines. And of course, prophylaxis cellulitis. But again, come back to our patients, larger areas of fibrosis, heart edema, papillomatosis with multiply proliferation, cellulitis, constant lymphorrhea. Papillomatosis growth is very fast, and that is why manual lymphatic drainage and home physiotherapy is not possible to do. The main question today and discussionable question is surgery, usage of surgery for the treatment patients with lymphedema. The indications for surgical procedures, severe deformity or marked disability due to the swelling, removal of redundant tissue after successful conservative therapy, recurrent cellulitis, lack of response to compression therapy, and other recommendations. And we must consider that surgery and management of lymphedema falls into categories such as extirpative reduction surgery, debulking surgery, open technique and liposuction, and lymphatic reconstruction. We have experience of clinical examinations and surgical treatment more than 800 of patients with different forms of lymphedema, and we performed resection operations, lymphovenous reconstruction, transplantation of complex tissue, indirect drainage of interstitial with usage of lip angioplasty and lymph aspiration. More often we used lymphovenous anastomosis in patients with primary lymphedema. We used nodular venous anastomosis when we had hyperplastic kind of damage of lymphatic system. We used lymph angiovenous anastomosis, and we combine different type of operations such as lipolymph aspiration and formation of lymph angiovenous anastomosis, and of course manual lymphodrainage. And when we had damage of venous system, we used endovenous laser ablation and lymph aspiration with receiving satisfactory results. But again, come back to our patients that I want to say that the first thought was in my mind, high amputation, how to apply a tourniquet, because inability to use cell saver in connection with expressed chronic infection and other. That is why we propose stage first lymph drainage using drainage of the original design. On the second stage, after 7 days, a linear dermalipopastectomy was performed on the thigh to enable the possibility to put a tourniquet, and on the stage third, formation of lymphonodular venous anastomosis together with lymph angiovenous anastomosis in the groin area. And after receiving such results, I was inspired. And I have recollected about Charles' operation, but I don't like such operation. Consider such unsatisfactory results after performing these operations. That is why I have decided to use Charles' resection operation on a shin, but modified with closing wounded surface and artificial histid covering that provides formation at optimum granulating surface. After that, linear dermalipopastectomy on medial and lateral surface on a hip with use of skin for closing wounded surface of a shin together with lymph angioplastics, and we have received satisfactory result after our treatment. Additional treatment included compression garments, self-massage, lymph transport promoting exercise, pneumatic compression therapy, and of course, according to all guidelines, we must use psychological support of such patients. I want to say in conclusion that on the example of the clinical case, we tried to show modern methods of treatment from early lymphedema to giant, which accumulated all the achievements available in the lymphology today, despite the discussions of many positions. This applies especially to use of lipolymph aspiration on the one hand, lymphovenous anastomosis on the other hand, place of the resection operations, but we are sure that conservative treatment is obligatory in all cases. The more opportunities the clinic and the professional own, the better results of the treatment the patients received. And future studies are needed to elucidate the biomechanism or psychological, physiological techniques, and randomized controlled trials are required to identify the best surgical interventions and their various combinations and permutations to better advise on a protocol for surgical management of lymphedema. Thank you for your attention, and I am open to your questions. Thank you very much for inviting me on such interesting webinar. Good evening.
Wow, that is what I have to say, Dr. Chernukha. Very impressive cases. Could you give us and the listeners an idea of, for this very impressive case that you started with and ended with, it was a huge huge improvement. Over what time period did it take for you to do all of those various procedures and for that patient to be evaluated, to have the different procedures, and to heal?
Thank you. I want to say thank you, first of all, for inviting me for such a webinar. And according to your question, approximately 3 months, we need for recovering and for performing all stages of such operations.
So how do you set expectations with your patients when they come in with such severe lymphedema?
Fortunately or unfortunately, such a woman was not from Ukraine. She was, I will not say about where she from, but I am suspecting that such a woman had congenital form of lymphedema with very, very strong progressions without necessary or additional conservative treatment, maybe.
Okay. And
but I want to say that the first thought was in my head how to do amputation in such patients, because it was absolutely a dramatic and terrible situation when I saw her in my office, and you can imagine the smell.
Oh yeah.
It was absolutely terrible, terrible clinical picture and smell. But it was a young woman with daughter, with husband. It was terrible.
Wow. Well, that is a truly dramatic improvement and an amazing case. How did you control the drainage after all of those procedures?
It is very interesting question, because the main aim of my operations, all stages of my operations, was on the initial stage was to achieve such results, such condition of limb which will allow me to do amputation. Because I could not imagine that it will be possible to achieve such results as we achieved. And the control of lymphatic venous anastomosis and other, it was not very important for us. But we used, at that time, we used lymph scintigraphy with radionuclides.
All right, thank you. Any questions from our panelists for Dr. Chernukha, or any comments?
I'm just curious. Thank you so much for such an impressive case. If you had to do an amputation on such a lower extremity, how would you be able to manage the swelling post-operatively so that you have an appropriate wound healing process?
I'm sorry, I could not hear you very good. Maybe you repeat your questions more slowly. Is it possible?
Absolutely. When you have such a swollen leg, one of the challenges that I think most of us have is managing the swelling after an amputation. How do you manage that yourself in your practice?
Of course, we used usually we used complex decongestive therapy, such as manual lymphatic drainage and compression therapy. And in our clinic, we like to use different type of pneumomassages, and sometimes in such situation, particularly in the cases of severe forms, we used drugs too. Such drugs as anticoagulants and different drugs which can help us to improve rheological condition of the body. It must be obligatory, particularly in situation when we have severe forms of lymphedema.
All right, thank you. I appreciate that, and I'm sure there will be more questions as we go along. I see Miss Dancey has joined us. She, as I mentioned, she's a consultant plastic and reconstructive surgeon from the United Kingdom, and has a, hey there, and welcome. And we have a recorded presentation from her. If you could play that now.
It's a privilege to be able to talk to you today about the surgical management of lower limb lymphedema. I'd like to go through how we select patients, imaging modalities that are used, and the surgery itself, which is divided into physiological surgery to restore lymphatic function and debulking procedures. Patient selection is key to the success of these techniques. And all patients should be started with conservative management, which is the mainstay of treatment. Clearly, not every patient is suitable or ready to have lymphatic surgery. The ideal patient has tried conservative management and it's failing. They suffer from chronic infections or pain, and these are key indications to perform the surgery. We need patients to be compliant with the conservative management, have imaging pre-surgery, and the sooner you get to do a physiological technique, the more likely you are to restore lymphatic function, although it can be used in patients who have long-standing lymphedema. So in there are three main modalities used in lymphedema surgery. The first one you're all familiar with is a Lymph Syntagram. Obviously this involves radioisotope and it's not always easy to get hold of it. You do get great imaging of the deep lymphatics, but there's no anatomical detail and it's easily obscured in patients who have fat deposition. MRL in the middle is a slowed down image in an MRI, which gives you specific anatomical detail of the deep and superficial lymphatics and is fantastic at surgical planning and anatomical detail. On the right, we have video fluoroscopy using ICG dye, which you can see is injected in a bolus, and you can follow the lymphatics real time up to the lymph nodes and actually see pulsation in them. And I use this mainly in surgery to ensure that I'm not removing the sentinel lymph nodes. Lymphedema surgery itself is aimed to either debulk the limb by liposuction or even excision of skin and subcutaneous tissue, or to restore lymphatic function. And in my hands, I believe that the vascularized lymph node transfers are the best technique, although there are various options and not one fits each patient. So a lymph node transfer involves harvesting healthy lymph nodes from a donor site using their artery and vein to reattach to vessels in the recipient site. Thereby the tissue is vascularized and we harvest about 4 lymph nodes. So that seems to be adequate looking at previous studies in managing the lymphedema without risking problems at the donor site. To my mind, not only is it introducing lymphatic tissue, but it allows me to remove all the tight bands around the blood vessels, lymphatics and nerves, and prevent the scar tissue from readhering by bringing in padding of vascularized tissue. This allows the lymphatics to open up where previously there'd been a scar obstruction. Don't forget that the primary role of the lymphatics is a functioning immunological role, and lymph node transfer introduces lymph nodes which resume this role and will reduce the incidence of cellulitis. The relief of symptoms in terms of the pain, the aching, the heaviness, and the infection is almost instant. I had to put this slide in. So this is a cancer cell actually surrounded by lymphocytes which are identifying and destroying it, and by introducing lymph nodes back into the area we're restoring. Evidence-based medicine shows good improvement with lymph node transfers, and in fact I believe that results are getting better and better. This is a study from 2016, but they showed a 74.2% improvement in upper limb lymphedema and 53.2% in lower limb. Lower limb is more difficult, partly because of the weight of gravity and the fact that there's longer for the lymphatics to go and re-establish. This is what I use intraoperatively, so I inject ICG dye in the upper arm in arm patients and the thigh in lower limb patients. Now, this is a dye used to identify the sentinel nodes for cancer surgery. I want to see these nodes and I want to leave them behind. Clearly, if I start taking sentinel nodes, I'm going to cause lymphedema in that limb potentially. So the idea is to image the sentinel nodes and the nodes draining the leg, and then not harvest them. Make sure you go to alternative lymph nodes. This is with the eye of faith, a lymph node transfer, and this is the donor site in the groin, and you can see there's an artery and a vein there supplying those lymph nodes. It's not a large amount of tissue we take, we don't want to, but this contains 4 little nodes that I could palpate. That's the donor site, and that's the size of the flap after harvest. The vessels are really quite small, so they're certainly less than 2 millimeters in diameter at that level. And we harvest them as close as possible to the femoral artery to ensure they're as large as possible. This is the anastomosis being performed, and this is in fact the flap artery to the recipient site. We reattach the artery and the vein and not the lymphatics themselves. There seems to be no advantage to trying to reattach multiple lymphatics, as it works with just the vessels supplying it. And I thought I'd put in some post-op photographs. Forgive me for some of them being upper limb, but it gives you a little bit more detail than lower limb, and it's exactly the same principles. So on the left, you have a patient with left arm lymphedema following breast cancer surgery, and that's her results at 3 months post-operatively. She also had liposuction of her arm, which you can see here. So once the lymphedema had resolved, then we often perform liposuction to remove the fat deposition that you get with long-standing lymphedema. On the left, you have a patient with right arm lymphedema, again following breast cancer surgery, and these are the results after a lymph node transfer and shaping liposuction. These patients no longer wear garments, which is often achievable in upper limb. In lower limb, they're more likely to be in garments long time. This is an interesting MRL scan. So on the left side, you can see where the patient's had a lymph node dissection, and there's a blockage to the lymphatic function with no drainage. And this is exactly the same limb after a lymph node transfer, and you can actually see where lymph nodes have been put and how the lymphatics have reopened up again to establish flow, and you can see the size of the arm is significantly reduced on the scan. LVAs are a very well used and recognized technique. They're simpler than free flap surgery, and it simply involves detaching a vein and reattaching to a local lymphatic. The surgery is less successful than lymph node transfers and it doesn't restore lymphatic function, but it can certainly reduce the size of the leg. The reason it's less successful is these are very fragile vessels and they often collapse under the pressure of the surrounding tissue. My worry about doing this is you need to reattach 4 locally functioning lymphatics to veins, and there's a risk that you could cause worsening lymphedema of that limb. To my mind, that's not worth it. With a lymph node transfer, you don't risk any worsening of the lymphedema. It's a given that you need to adequately consent the patient in that they may have a risk of lymphedema at their donor site in a lymph node transfer, but using the retrograde imaging, I certainly haven't had any of these problems. Liposuction. This is an excellent technique to reduce the size of the limb, and it can be used in isolation, although the patient will need to continue wearing compression 24 hours every day. And it could also be used as an adjunct to a lymph node transfer or any other technique to shape the limb and remove the residual fat deposition that lymphedema causes. So you can see with liposuction, remarkably, although it removes the fat, it protects the lymphatics. And we used to think that that kind of honeycomb tissue was just fascia, but it's not. It's got lymphatics and blood vessels within it, and they seem to be protected. There's no evidence of damage on MRL scans. These are just images of limbs that have had liposuction alone with no lymph node transfer. Not every patient's the same. Lymphedema surgery is tailor-made. It's a combination of techniques suited to the patient. In conclusion, surgery for lymphedema improves quality of life, but it's not suitable for every patient, and it's key not to overpromise results and to manage the patients appropriately pre and post-operatively. Key to success is a lymphedema team with lymphedema nurses, physiotherapists and colleagues to support you. If you'd like to contact me in any way, please do not hesitate to do so. I'm more than delighted to talk about patients that if you're having problems. Thank you for your time.
Thank you, Dr. Dancey. Again, amazing results. One of my first questions for you has to do with the imaging you showed, the MRL. When you obtain these on the patients as part of your selection process, what are you looking for on the MRL that would lead you to believe that an lymph node transfer or an LVA would or would not be successful?
Yeah, that's a good question. So actually, my thinking is that I'd rather image the donor site than the recipient site, because I want to make sure that there's no underlying lymphatic dysfunction there, because if there is, I'll go to the other limb or go to the other axilla. Because I think some patients might have some compromise that you haven't clinically picked up on, and it's just essential to rule them out. Otherwise, I might give them lymphedema. Also, I'm looking at the leg itself, at what deposition there is from fat and fluid and where it is. So that might guide me to put lymph nodes in a different place. So you could put them to the knee or even to the ankle, although actually I believe that particularly when they've had surgery, and that's the reason that they've got lymphedema, you've got to release all that scar tissue, because I think that's key to this, as well as the lymphatics. So mainly I'm looking at whether they're going to need liposuction afterwards, so that I can guide them and explain that, and just checking that the donor sites aren't compromised.
All right, thank you. My other question has to do with what the patient needs to do on their end, whether it is stay in town, lose weight, be on some type of specific diet, low salt, any type of diuretics. How do you counsel the patients to do their part to ensure that they are going to have good results or the best possible?
Yeah, absolutely. I think the first thing is you've got to make sure that the patient understands the limitations of the technique and that they've got maximum lymphedema nurse input. So sometimes if they've got a very edematous leg, we're going to bandage them preoperatively, because I think it's key to get that fluid down as much as possible before you start embarking on surgery. So once they're as best optimized as they can be, then we would do the lymph node transfer. Now, we tend to leave it for 5 days without putting compression garments on, and then we start to introduce them again. My lymphedema nurse is key to this, really, because we often find at about 12 weeks, everything seems to slow down. And whilst there's been an initial reaction, then suddenly it's a bit sluggish, and it tends to be the middle of the forearm or round about the knee and the top of the lower leg that's the worst area. So at that point, we rebandage them. And I think just pushing that extra fluid out and giving the little lymph nodes a chance to drain it, they then take over from where they are. And it seems to work really well. And we've had really good results, even on primary lymphodemas in the lower limb. So although I never used to do primaries, I always used to say, look, I know that you've had lymph nodes removed, and then that's likely to be the key to replacing them. Actually, I did try it after spending some time with Corinne Becker, and I've been really encouraged by the results. But I think the mainstay is really having a patient who's sensible. They're going to comply with you, because there's no point doing it in someone who's not. It's a waste of their time and money.
So my last question, which is for both you and Dr. Chernukha, is you mentioned patient selection is critical. Who would not be a candidate? Who would you say, no, I cannot help you?
I think, well, for me, it's mainly whether the patient understands it and they're willing to comply with the treatment. I've done it on long stay. In fact, the first photo I showed you of the hands, she'd had her lymphedema for 20 years. So, you know, you still can get good results when they've had it a long time. For that reason, that wouldn't be a contraindication to me. I think if a patient was ill, they had poor health, they weren't really a candidate for free flap surgery or being 4 hours on an operating table, then I would do it on them.
Okay. Anything to add, Dr. Chernukha?
Yes. Thank you very much for your very interesting data. The question is about your attitude to the usage of surgical procedures in the patients with earliest form or easy forms, soft forms of lymphedema. Is it your principal approach, or maybe you showed only some cases? The main question is your attitude to the conservative therapy in such cases, because, for example, in our country now we are preferring use conservative treatment on the initial stages of lymphedema, especially after, for example, breast cancer surgery. And in such cases, we usually use conservative treatment, manual lymphatic drainage, different compressions, garments, and other procedures. What is your opinion? Because you demonstrate early stages, stop stages of lymphedema.
So for me, well, most patients, when they come to see me, they've had failure of conservative treatment. So, you know, the mainstay is absolutely conservative treatment. I'm not proposing that everyone is suitable for surgery or goes for surgery. And some patients manage very well with compression and MLD. Having said that, I have had the odd dilemma with a patient who's got very sort of minimal lymphedema or subclinical lymphedema, who's just paranoid it's going to get worse and wants you to do something. I've done it once in someone with very mild lymphedema for those reasons, but she was very young, you know, and wanted babies and family and was just petrified that she was going to get lymphedema of her arm. So I've done it in her, and obviously there's been more recent work with preempting this, and actually at the time of lymph node dissection, going in and reattaching the lymphatics to cut vessels, and that's been excellent results, and certainly something that I would try. My problem with where I work is that there's just not enough surgeons to cope with the number of operations being done to be there at each surgery. And my practice is in the UK, but I'm also in Cayman, and I go out there for periods, and there you've got a whole different scenario where the physios are the only people that can manage lymphedema because there are no lymphedema nurses. So that's another world where it's difficult to manage, and even getting garments is difficult. So, so it is very situational depending on what resources you have too.
Thank you. And I have a next question about how did you check the function of lymphovenous anastomosis?
That's a good question, actually, because we bury the flap. So because it's not a huge flap, I don't keep the patients in, they go home the next day. And I guess the only way you're going to know whether it's working or not is whether you can see differences functionally, but I'm not going to go back in and try and change that flap. If it's not going to work at that attempt, then I don't see any point in going back in and re-looking at it again. So I bury it and I don't monitor it.
Thank you.
All right, thank you both. And thank you, Dr. Dancey. Why don't we move on across the ocean to the United States and hear from the doctors at the Mayo Clinic in Jacksonville, Florida. We'll first hear from Dr. Young Erben, vascular surgeon at Mayo Clinic in Jacksonville, Florida. Dr. Erben.
Good morning, and thank you so much for the kind invitation. Thank you, Dr. Bush, and the entire panel group. These are really amazing operations. I'm sharing my screen. If you see them, let me know. So this will be more of a pre-empty presentation of when you evaluate the patient that comes to your practice for leg swelling. So I'm a vascular surgeon, and honestly, this is one of the most common indications for referral to our surgical practice. And I'll introduce Dr. Ho, who does the lymphovenous bypasses at our institution. So the objectives of our talk today is to basically understand the common causes and less common causes of leg edema, formulate a differential diagnosis, and describe a systematic focused approach to evaluating the patient with leg edema. So again, as I stated initially, it's one of the most common consults made to vascular clinic. And unfortunately or fortunately, the reasons for leg edema are diverse. And my presentation is going to focus in those patients where the leg swelling is due to lymphedema. So the definition is the accumulation of fluid in the interstitial space. And this can occur rapidly by the development of generalized pitting edema, and in a chronic fashion when the accumulation of edema occurs in one or both legs and is a little more subtle. In the case of lymphedema, we grade it depending on the depth of the pitting edema, and one of the classifications that we do have is looking at the depth of the depression when we do press on physical examination the skin of a patient. The most common causes of bilateral or extremity swelling in the acute setting are medications, heart failure, nephrotic syndrome, and venous thrombosis. Most commonly cable thrombosis because it affects both lower extremities. The most chronic causes could be venous insufficiency, could have been a pregnancy, malnutrition, inflammation, dependent edema, liver disease, idiopathic, and again, lymphedema in the latter cases. So now the consideration that we have to do when we are evaluating a patient with lymphedema is this lymphedema or is this lipedema, which many times could be very puzzling at the time of a physical examination, but a good history taking can help us elucidate the difference. The lymphedema involves the leg swelling, the ankle or the foot. The toes are sausage shaped. The skin is indurated. And again, the ones that we do treat or manage surgically are following trauma, surgery, infection, radiation is another cause. And also it can occur spontaneously, and depending on the part of a world that we are living in. However, lipedema is more of a familial pattern. It shows a lack of improvement with compression therapy, and it's primarily a clinical diagnosis. So these are the things that you need to keep in mind when you evaluate a patient with leg swelling. Many times it is a little bit confusing to differentiate between lipedema and lymphedema. The primary lymphedema is congenital, and when it is non-familiar, it could be non-familiar and familiar, which is Milroy's disease, which is an autosomal dominant entity. Lymphedema precox in the patients that are from ages 1 to 35. This is mostly non-familial. If it is familiar, we have Meigs disease. This is an autosomal recessive. And the lymphedema tarda, which the age of onset is beyond the age of 35 and mostly secondary in nature. Secondary lymphedema, which is the most common cause of lymphedema that we manage and treat, is due, again, due to cancer, secondary to lymphadenectomy and radiation in the patients with breast cancer. 20 to 30% of those breast cancer survivors will develop secondary lymphedema. And depending on the area of the world, filariasis, which is most common cause of secondary lymphedema in developing countries, and trauma, post-surgical, and infections. So any lymphadenectomy or lymph node dissection, you just have to be careful and warn the patients of potential lymphedema consequences. The diagnosis, again, and the physical exam is a non-pitting edema, involves the dorsum of the foot and the toes. You have a summer sign, and may have concomitant venous disease. It does not preclude, lymphedema does not preclude venous disease. You can have both. And it is important to obtain an ultrasound in all patients that you're evaluating with leg swelling. Now, the non-operative management that we do offer at our institution, it is, as Dr. Dancey has mentioned, it's a multidisciplinary fashion. It is extremely important to have a compliant patient. The most important thing that we tell a patient is elevation, compression garments in the form of stockings, but other garments that we have. Lymphedema massages, so we have to have good therapists and nurses involved in the care of our patients. Drainage, pumps. It is a little bit challenging in our country to have to start the process for getting approved for lymphedema pump. But once you start this, it is very helpful to the patients. And obviously you have to have a very compliant patient. Another aspect that we offer as part of the multidisciplinary fashion team that we have is weight management. We also offer consultations with a bariatric team. And it is also extremely important to have a dermatologic care of skin afflictions, including antibiotic therapy. You may have, infections on top of everything else that you have. And again, once the non-operative management is offered and the patient is compliant, that's when we introduce the patients to the consultation with the surgical management of lymphedema with my colleague, Olivia Ho, who is a microvascular surgeon and specializing in the plastic surgery. Thank you.
Thank you, Dr. Erben. Why don't we go, since you all are part of a multidisciplinary team and work together as a team, why don't we go to Dr. Ho, and then we can ask some questions following that.
Thank you.
Thank you so much for the introduction and the opportunity to speak today. I'm going to just screen share so that is everyone able to see the slides? Okay. So my name is Olivia Ho. I am a plastic reconstructive surgeon at Mayo Clinic, and I work with Dr. Erben. So I have no disclosures. I know that some of the things that I'll go over today there's going to be some overlap, and I think this is good because there's some of the things that are similar and some of the things that are different, which will generate some discussion. And as Dr. Erben already mentioned, there's primary and secondary lymphedema. And we see both. Secondary is more and more common just based on the type of cancer care that we need to do. And in North America, most commonly it is with cancer care, but globally, still most of the common cause is Wucheria bancrofti or filariasis. The pathogenesis is with the lymphatic system, it regulates the body fluids, transport lipids, and also is responsible for immune cell trafficking. But when there's a dysfunction, that's when you have regurgitation of the lymphatic fluid in the subdermal lymphatics, the interstitial compartments, and that is what leads to swelling. But it doesn't just end there, because when you have chronic lymphedema, you then have cellulitis and sometimes multiple hospital readmissions for that. And that leads to tissue inflammation and fibrosis and hyperkeratosis. So with workup, there are differences between surgeons, between institutions. Lymphoscintigraphy still remains the gold standard for diagnosis of lymphedema. And so our group, myself and along with my colleague, Dr. Forte, we do obtain lymphoscintigraphy. And then ultrasound, of course, is important to determine if there's any type of venous problems that are associated with it. And CT scan, different people use it differently, but I primarily use it to look at whether it is a fat or fluid predominant lymphedema, so the type of tissue makeup. And circumferential measurements are important. There's much debate as to how they should be performed, whether it's just two separate measurements based on a certain distance from a landmark, or is it every 4 centimeters? So we do it every 4 centimeters, and we have a multidisciplinary approach with our physiotherapists so that it's a consistent measurement, and generally always done by the same two specialized physical therapists. And bioimpedance spectroscopy is also a possibility. With a lot of things with lymphedema, a lot of debate, even with the stages of lymphedema, there is difficulty with agreement between global experts in it. But generally speaking, it ranges from stage 0 to stage 3. And stage 0, it's subclinical. Patients may not have true swelling that's visible, but they describe a sense of heaviness or decreased range of motion. And then with stage 1, you see pitting edema, it's visibly swollen. Stage 2, non-pitting edema, you start to have tissue fibrosis. And stage 3 is when it's quite severe and you start seeing irreversible skin changes. It would not be possible to do a talk without paying our respects to some of the pioneers of lymphedema surgery. I know that Ms. Dancey already mentioned that she had visited Dr. Corinne Becker in France, but Dr. Corinne Becker has done some of the most numbers of primary lymphedema cases with predominant groin vascularized lymph node transfer. Dr. Koshima in Japan is the master of Lymphovenus Anastomoses and has probably one of the largest collections in the world. Dr. Hakan Burson from Sweden, largely a lot of discussions with debulking and liposuction. And my mentor, Professor Mingwei Zhang in Taiwan, who really has inspired me to look at all aspects of not just the pathophysiology, but kind of thinking outside of the box and what makes things work and what makes things don't work. And I won't spend a lot of time in non-surgical treatment because I know that Dr. Erben has already talked about this, but very important and has shown the most consistent, and it's been around for the longest time. And patients continue to sometimes, unfortunately, still need it after surgery. And so very important that they are compliant with this. And we work closely with our specially trained physical therapists that have a sub-interest in lymphedema. And so it's a combination of techniques as already described. So surgical options. Candidates for surgery, I know that across the board, people have said that it does need to be, patient selection is very important, and they need to have tried optimal conservative therapy. And I say optimal because it's not just the length of time, but the compliance of the actual conservative therapy, the wrapping or the garments. And different surgeons have different feelings as to what an optimal time frame is. So my partner might consider 6 to 12 months, but I ideally want them to have at least 12 months of optimal conservative therapy. And if that doesn't work, before we consider any surgical options, if they are a candidate. Compliant, I know that that's something that mentioned across the board. No active infection, because of course, if they have an infection concomitantly, that can affect their surgical result. And normal venous system, because a lot of the times with some of the surgical procedures, whether it's LVA or vascularized lymph node transfer, we need to rely on a healthy vascular system to bridge it to. And if they have some other concomitant vascular issue, then that may not work. And I put BMI and age in a gray color because that also has some variability. We have differences for our cutoff for upper extremity versus lower extremity lymphedema based on BMI and age, because of course those can affect your surgical results and outcome as well. So surgical management, I still kind of follow this kind of general guideline. I know everyone is a little bit different, as I had mentioned, just for the entire field of lymphedema and lymphedema surgery, especially in the last 5-10 years. But I see it as when they are in a lower stage of severity, we would consider LVAs, lymphovenous anastomoses. And then as they progress to more severe stages, partly because the tissue is very fibrotic and has permanent changes, and you may not be able to really reliably do some of the more fine and finesse surgical procedures like lymphovenous anastomoses, vascularized lymph node transfer. So that's when it leads to liposuction and excision. So talking about lymphovenous anastomoses, essentially, we know that there is a problem with the lymphatic system. And I describe it as you have a block in the highway and you're boring or transferring some of that backup into the venous system and using that to bypass your flow. And it's first described in the 1960s, but essentially the microsurgical bypass procedure is even smaller than some of the microsurgical procedures that we normally do. So if with free flaps, whether it's head and neck reconstruction, breast reconstruction, we're re-anastomosing or anastomosing vessels that are about maybe 1, 2, or 3 millimeters in diameter. But the lymphatic channels and the superficial venules are usually in the range of 0.5 to 0.8 millimeters. And you do need to have a competent venous system in order for this to work. And it's arguable also as to the efficacy, but many people argue that the more that are done, the more LVAs are performed, the more efficacy there are. But of course, it needs to be draining. You can't just do a bunch of them in the same place. So there's much debate about that as well. But generally speaking, more up to a certain degree is better than less. So we start off with intradermal injection of indocyanine green, and then we use a infrared light fluorescence enhancement. So we use the photodynamic eye, and this helps us find and identify the sizable lymphatics for anastomosis. You can also use the ICG for tracking lymphatic recovery after LVA as well. And so here, this is a picture of a lower extremity. The toes are towards the right side, and then the knee is towards the left. And we mark out the areas of where the veins are and where the lymphatic channels are. And if they're in kind of close parallel, you would have transverse incisions across the skin to perform the anastomoses. And this is kind of showing the measurements of what they are, typically kind of in the range of very much smaller than 1 millimeter diameter. And you can do it end to end, end to side. Much debate about that as well as to what is best and what is most ideal. So with end to end, it's a much an easier anastomosis, but there are proponents that argue that if you do end to side, then you are still allowing the flow of the venous channel, but you allow the diversion, but also still allow the flow, so you don't disrupt another vessel. And here in this example, you have intraoperative assessment of the patency with ICG, and this is, in this case, is an end-to-end. I mentioned the study briefly, though this is they had a small number of subjects in it, they did find that there is a decrease in dermal fibrosis with LBA. So it did show that with LBAs, it does remodel the subcutaneous tissue. So I think it's always promising when we can see not only just clinical changes, but also histological changes as well. And this is one of my patients. So on the left side, this is like, it's the pre-op. And then post-operatively, even though the left leg is still swollen, you can see that there's decrease in the circumference, but also increased number of wrinkles that are at the ankle joint. So there's visible decrease in it, but also what's important is asking patients how they feel afterwards, whether there is more range of motion and lightness, and ultimately the goal is to get them to be able to wear compression garments less. The next thing is vascularized lymph node transfers. This is a busy slide, but essentially in this study that we compared the groin versus the submental donor site, but also wanted to discuss the various different types of donor sites there are. There's submental, groin, omentum, supraclavicular, axillary, jejunal, mesenteric, and they each have a different vascular supply. I know that Ms. Dancey had mentioned that she doesn't typically monitor her flaps, and I think this is much debate as well. Do we monitor them? Do we not monitor them? But typically when you do a free flap, one of the ways to check whether there is good blood flow or not is to see if there's good color to a skin paddle, or assessing it with the Doppler at the bedside. But this can be tricky with very small flaps that you use for vascularized lymph node transfers. And for things like the omentum, it doesn't, and the jejunum mesenteric, it doesn't come with a skin paddle for monitoring. So you have to kind of rely on other measures. And they each have their pros and cons, advantages and disadvantages. But the main thing that we worry the most about is creating lymphedema at the donor site. So Joe Diane and Mark Smith in New York, they popularized the reverse lymphatic mapping technique. And essentially this uses technetium and also indocyanine and green so that you can differentiate which lymph nodes are the ones that are draining the upper or lower extremity, so that you can avoid those lymph nodes when you harvest a vascularized lymph node transfer, and then you can have a better chance of avoiding donor site morbidity with or developing donor site lymphedema. So just quickly, this is an example of a groin vascularized lymph node transfer. Submental, with a submental, what you worry about is damage to the marginal mandibular nerve, and also much debate as to how acceptable the donor site scar is, given that it's so visible and it's on the face. And that's some of the big criticisms associated with it. Supraclavicular, popularized by Dr. David Chang, who used to be at MD Anderson and currently is in Chicago. But one of the big things you worry about is chyle leak, because you could get into that area. And he, because he's done so many, and he has also described what has happened when he's had to painstakingly wait for that to resolve in patients who develop that when you use this as a donor site. Omentum. Nice thing about it is that it's very, very unlikely to develop donor site lymphedema, but it's very floppy, and it's with regards to stability and whatnot, it can kink, and there's no skin paddle associated with it for monitoring, and it can be big and bulky. Jejunum mesenteric, a little bit smaller, but again, no skin paddle. So in this study, it was very fortunate to work with my mentor, Professor Zhang. And in plastic surgery, we know that there are many different types of tissue that have ischemia time. So bone, skin, muscle. Muscle has the shortest ischemia time, and we know that time is of the essence, but no one had really studied the ischemia time for lymph nodes. And so what we did was we took rats and we harvested groin flaps, and then clamped the vessel at various time periods, released it at an hour, and assessed it from a histological standpoint using Doppler, and also using ICG to see at which point is it the point of no return. And we found that at 5 hours, that's the time that is critical ischemia time. Generally speaking, for free flaps and microsurgery, we want to be able to do the anastomosis within that time, or we don't disconnect the flap from the donor site until it's ready to be transposed and re-anastomosed to the recipient site. But now we know kind of where it sits in terms of other types of tissue. Debulking procedures. It's not advancing here. Oh, there we go. Okay. So liposuction, the most common, but one of the things that's different with liposuction of lymphedema tissue versus liposuction for, say, cosmetic reasons is whether the use of tumescence. So traditionally, with liposuction in the past, when we first did it, it was dry liposuction, and then a dermatologist had actually discovered that if you use tumescent solution, that decreases the amount of blood loss and pain. So generally speaking, most surgeons will use tumescence. But when you have a limb that is lymphodematous and fluid filled, and you put more fluid in, sometimes that just seems to be a little counterintuitive. So many proponents of dry liposuction associated with lymphodematous limbs, but Dr. Erben made a good point about, at the time of diagnosis, we wanted to differentiate between someone who has lymphedema and lipedema. And someone who has lipedema is a different type of story. And so in those patients, we probably would still do tumescent solution and liposuction because it's a different disease entity. Some of these are historical, but rarely can be applicable to some patients. So if they have severe lymphedema, elephantiasis, Charles' procedure essentially is very morbid. You remove all the lymphodematous tissue and you put a split thickness skin graft there, and so it makes the limb smaller, and it helps decrease the bulk that's there. But you do need to borrow skin from another site, and you need to graft it there, and you need to make sure that the grafting will survive at the recipient site. Cyst-trunk procedure is just excising the ellipse of tissue and then primary closure. Some of the common things that crosses over to, say, when we do a brachioplasty for cosmetic reasons, you can have decrease in sensation because you're taking out the full thickness of the tissue along with the superficial sensory nerves that are there. And Thompson is very similar, but just from the lateral aspect. And there's a little bit of a vest over pants fashion where you have just not direct apposition. So if there is a dehiscence, you're not directly staring down into the deeper tissue. Professor Hangji Chen, who also is in Taiwan, but is in Kaohsiung, also quite a pioneer in microsurgery, but does a lot of lymphedema surgery as well. He proposed a radical reduction of lymphedema with preservation of perforators. So it combines kind of a debulking procedure, but also looking at the small blood supply to the tissue so that it could potentially be a little bit less morbid in removing that extra tissue. But of course, this would work better in someone who doesn't have a very, very severe and fibrotic tissue. Preventative surgical techniques I'm going to touch on briefly. Lympha is a lymphatic microsurgical preventative healing approach. It was pioneered by Klimberg, and it's based on the observation that lymphatics and nodes draining the breast are distinct from those draining the arm. And I know that we are supposed to focus on the lower extremity. I will kind of touch on that in a bit, but commonly right now, lympha is being suggested for breast cancer cases, although I'll show you later on in the talk that it has been done for lower extremity as well. But the idea is that now that sentinel lymph node biopsies are done, the rate of lymphedema is much less. But occasionally you will have patients that need an axillary dissection and their risk of lymphedema is much higher. So what can be done in that case if you know that they will have a high risk of developing lymphedema and you want to prevent it? So the idea is to, after the axillary dissection, and in this case, this is by Drew Singal, who's based out of Harvard. He uses a completely different dye all together, so it doesn't get lost in the mix of things. So we have technetium-99 blue dye that's already used by the breast surgeon. But in addition to that, we'll use fluorescein as a separate injection so that we can differentiate, and we want to find the cut lymphatic channels and connect it to a vein, so that, again, the idea is to divert the flow. Otherwise, these loose ends, whether it's the venous side or the lymphatic side, would just be clipped off and then left as dead ends. So the idea is to connect that so that you can divert the flow, decrease the risk of lymphedema. And it's a little bit blurry, but you want to kind of have a competent valve, because usually the vein is much larger, and then anastomose the lymphatic to usually say the axillary vein or a branch. And here it is again, using the indocyanine in green. And this would be an end-to-end, but you could have multiple venules going to the same vein because generally there's a size mismatch. So this was a literature review of all the studies that have been done so far for lympha. But you can see in this column where it says extremity, predominantly most of them have been on the upper extremity. A few have focused on lower extremity. And I think that that is an area that we should explore more in the future, because definitely either upper or lower extremity lymphedema is very unfortunate for the patient, and if there's a way in which we may be able to prevent it, that is a goal. So in conclusion, limitations of surgery, it's not curative. Patients do need to be counseled about that. It doesn't address the underlying pathophysiology of lymphedema, and the long-term effects of that is still not fully understood. But in most cases, with proper patient selection, proper surgical selection, you do have improvement in the severity of the disease, reduces the complications related to lymphedema, such as recurrent infections, cellulitis, hospital admissions, and improves patients' quality of life. Thank you so much.
Thank you, Dr. Ho. That was tremendous and a lot of information from all of our panelists today. We just have time for a couple of questions, but one I have is, in North America, we don't receive much training or exposure to lymphedema. And then you go into practice and the patients, such as Dr. Erben talked about with the swollen leg, or who have even conditions such as you showed, Dr. Chernukha or Dr. Dancey, come into your office. And besides saying, would you be willing to travel from Texas to Florida, which most people aren't, how do we start? I think that would be one of my questions, is how do we start a lymphedema multidisciplinary group? How do we find interest? And I'd love to hear from you on how to get started on doing that, because there are so many patients.
I think that's a great question, Dr. Bush. I think it's one of those things where it's hard to, there's a lot of people that are interested, it's hard to get all the right together. But I don't have a quick answer for that. But in terms of the nuances of the details, you do need really well-trained physical therapists who subspecialize in it and have an interest in it. Microvascular surgeons for vascular and plastic surgery, and it's a great question, and I think that I think that it's in the last 5 to 10 years there's been more interest in it than before. About 10 years ago, it's just been, well, this is just what you have, and lifelong therapy, deal with it, and then that's just the end. But I think that we're turning a corner, and now it's becoming more and more researched, explored, and treated.
Thank you. Yes, I feel, especially in my part of the world, is that these patients sort of get put on the back burner, that they're told there's nothing we can do, go home and find some compression and live with it. And it's unfortunate. All of you have shown some amazing results for these patients. So I'm actually very inspired by this webinar. Any last comments? Because we are actually out of time. pearls, words of wisdom. You've given a lot. All right. Well, thank you again. I appreciate all of our panelists. This recording will be posted on the Vein and Lymphatic University site, so it can be watched by many. I would like to remind everyone of our November 6th EmPowHER series, which will be on strategies for taking care of patients with venous ulcerations. So thank you again for joining us on a weekend day, and have a good one. Thank you.
Thank you.
Thank you so much.
Bye-bye.
Bye.